let's talk about this very, very important topic, not only from the college point of view, but usually there are 1 or 2 questions in the MCQ exams as well. And this is regarding colorectal polyps and cancers. Now, colorectal polyps have also been covered by Dr. Illa in great detail. So I would strongly recommend that when you are doing this module, for finer details regarding the pathology, you can even refer to those notes or that video, and you can prepare your notes in a combined manner as well. So let's start talking about colorectal polyps now. Colorectal polyps can be of various types. The first one is inflammatory colorectal polyps. You can have hyperplastic colorectal polyps. There can be hamartomatous colorectal polyps. And you can have adenomatous colorectal polyps as well. Right? So first let's talk about inflammatory colorectal polyps. Now, inflammatory colorectal polyps, they can be associated with ulcerative colitis, and when I've spoken about inflammatory bowel disease, I've covered these pseudopolyps which are seen in ulcerative colitis. You can see that these are the pseudopolyps which are seen, and these pseudopolyps per se are not malignant, per se are not pre-malignant, but inflammatory bowel disease UC can increase the risk of colorectal cancer, right? So it is the area in between the polyps which can undergo malignant change, and you know ulcerative colitis has a higher risk of malignancy than Crohn's disease, but the pseudopolyps per se are not pre-malignant. Now, inflammatory polyps can also be there in the rectum. Inflammatory polyps can also be there in the rectum, and the patient is going to come with pain. The patient can come with pain, patient can come with bloody diarrhea. Patient can come with bloody diarrhea. And when you do a colonoscopy, you can see an inflamed rectal wall. There can be an inflamed rectal wall which can be seen. But I've already told you that these patients, the polyps are not pre-malignant, so we can just deal with the polyp by endoscopic resection if it's bothering the patient, but there's no risk of malignancy. Now, hyperplastic polyps are the most common colorectal polyps. So this is a very important question for the exam. These are the most common colorectal polyps, and the reason why these hyperplastic polyps are formed, there is decreased epithelial turnover. There is decreased epithelial turnover. Because of decreased shedding of cells, there is decreased epithelial turnover, and this leads to piling up of goblet cells. This leads to piling up of goblet cells, and that can give rise to these polyps. Again, these polyps are not pre-malignant. Again, these polyps are not pre-malignant. You should know this. These polyps are not pre-malignant, and they are usually seen in the 6th or the 7th decade of life. 6th or 7th decade of life. So these are hyperplastic polyps. Now, the 2 main polyps from which questions are asked in the exam are hamartomatous polyps and adenomatous polyps. So let's just discuss them in detail. First, let's talk about hamartomatous polyps. Now, hamartomatous polyps can be of various types. You can have a single juvenile polyp. There can be a single juvenile polyp. This single juvenile, as the name suggests, is a single polyp, and there is no risk of cancer. There is no risk of cancer. Then you can have juvenile polyposis syndrome. Juvenile polyposis syndrome can be there, and juvenile polyposis syndrome, this is associated with SMAD4 gene mutation. This is associated with SMAD4 gene mutation, juvenile polyposis syndrome, and there are multiple polyps here. There are multiple polyps in this condition, and this increases the risk of cancer. This increases the risk of cancer, juvenile polyposis syndrome. And this is an autosomal dominant condition, and single juvenile polyp, there was a single polyp. Here there can be 3 to 100 polyps can be there. So 3 to 100 polyps can be there in juvenile polyposis syndrome. Now, the one syndrome from which maximum questions have been asked, a short note is usually asked in the college exams, and maximum MCQs have been asked from Peutz-Jeghers syndrome. From Peutz-Jeghers syndrome. Now, Peutz-Jeghers syndrome, it is also a hamartomatous polyp syndrome. This is commonly seen between 10 to 15 years of age. Between 10 to 15 years of age. And this is due to mutation of STK11, LKB1 gene on chromosome 19. This mutation has also been asked in the exam. Again, this is an autosomal dominant condition, Peutz-Jeghers syndrome. And in Peutz-Jeghers syndrome, the features of Peutz-Jeghers syndrome are that there will be multiple hamartomatous polyps. There will be multiple hamartomatous polyps in this condition. These hamartomatous polyps have an arborizing pattern. They have an arborizing pattern on histopathology. Right, so if you look at the image, they have an arborizing pattern on histopathology, almost look like a tree and leaves coming out of it. And the pathognomic feature of Peutz-Jeghers syndrome, the pathognomic feature is perioral melanosis. Right? So you can see here in this image, perioral melanosis is there. This question was asked in the recent FMG exam as well. They had shown both these images, the arborizing pattern and perioral melanosis, and they had asked the diagnosis. So that the answer was Peutz-Jeghers syndrome there. Now, if we talk about the clinical features of this syndrome, the clinical features of Peutz-Jeghers syndrome, the most common presentation of these patients is in the form of obstruction. Is in the form of bowel obstruction. And why does bowel obstruction occur in these patients? So these polyps, the polyps act as lead points. Polyps act as lead points for intussusception. We've already covered intussusception and bowel obstruction, and you know that polyps are the most common lead points for intussusception. Similarly, Peutz-Jeghers syndrome, polyps can cause obstruction. And the most common site where these polyps are present, this has also been asked in the exam, most common site is the jejunum. Most common site is the jejunum. Patients can even complain of pain. Now, Peutz-Jeghers syndrome, this increases the risk of certain cancers. It increases the risk of certain cancers. One question which has been asked in the AIIMS exam, there is 100 times risk of pancreatic cancer in these patients. This was a question which was asked in the exam. Maximum risk of pancreatic cancer is with which syndrome? Peutz-Jeghers syndrome. Then these patients can also develop periampullary cancers. Periampullary cancers can be there. Thyroid cancers can occur in these patients. And these patients can also develop colorectal cancers. Colorectal cancers. Now, if these patients are going to come with intussusception, we have discussed the management of intussusception. It would usually entail doing a resection and anastomosis because it is due to a pathological lead point in this condition. So this was regarding Peutz-Jeghers syndrome. These are the points which you should know. This is the most important syndrome, so you should know each and every point regarding this syndrome. The other hamartomatous polyp syndromes which you should know about, the next one is Cowden syndrome. Sometimes Cowden syndrome has also been asked in the exam. Cowden syndrome, the gene mutation has been asked. So Cowden is because of a P10 gene mutation. This is P10 gene on chromosome 10. P10 chromosome 10. This is also an autosomal dominant condition. It is also an autosomal dominant condition. In Cowden syndrome, there can be multiple GI polyps. There can be multiple GI polyps, but what is important is that these GI polyps are not pre-malignant. So that is the important point which you need to remember. They are not pre-malignant, these GI polyps. In addition to this, these patients will have skin lesions. They will have skin lesions like lipomas and ganglioneuromas. lipomas and ganglioneuromas. And Cowden syndrome can increase the risk of, Cowden syndrome increases the risk of thyroid, breast, uterine cancer. Right, but the polyps are not pre-malignant. So this is regarding Cowden syndrome, which is another autosomal dominant condition which you should know about. Now another syndrome which can be a hematomatous polyp syndrome, another syndrome which you should know about is the Myers-Smith syndrome. This is the Myers-Smith syndrome, also known as the Banyan-Riley-Ruvalcaba syndrome. This is the Banyan-Riley-Ruvalcaba syndrome. So again, in this condition, Myers-Smith or Banyan-Riley-Ruvalcaba syndrome, there are multiple GI polyps, but the GI polyps are not pre-malignant. GI polyps are not pre-malignant. In addition to this, these patients can have macrocephaly. There can be macrocephaly, hypothyroidism, and penile pigmentation. And there can be penile pigmentation present as well in these patients. So this was Banyan-Riley-Ruvalcaba syndrome. The final syndrome which I want you to know is Cronkite-Canada syndrome. Now again, in Cronkite-Canada syndrome also there are multiple GI polyps. But the GI polyps again are not pre-malignant, and these patients will have ectodermal dysplasia. They can have ectodermal dysplasia. So ectodermal dysplasia, they can have alopecia, they can have koilonychia. And these GI polyps, as I told you, are not pre-malignant, but these patients can present with bleeding PR, bleeding per rectum, which can even give rise to anemia. So that is the presentation of Cronkite-Canada syndrome. Now you should know these syndromes, but in order of importance, I've already told you, Peutz-Jeghers is the most important. Cowden's has been asked after that. Both Cronkite-Canada and Myers-Smith have just been asked 1 or 2 times. But Peutz-Jeghers, you all should know each and every detail regarding that. Now moving on to the most important polyps, those are the adenomatous polyps, because these are the ones which have malignant potential and they can get converted into colorectal cancers. Now adenomatous polyps can be of 3 types. So adenomatous polyps, you can either have tubular polyps, there can be villous polyps. So this is a villous polyp, and you can have a combination of tubulovillous polyps. So these are the 3 types of adenomatous polyps which can be there, and adenomatous polyps increase the risk of cancer. Now what are the features which tell us that there will be a higher chance of cancer? So more the size, more the risk. More the size, more the risk. This is the most important, right? Larger the size, more is the risk. More the number, more the risk. More the number of adenomatous polyps, more risk is there. Right? Villous polyps have a higher risk than tubular polyps, and a sessile polyp has a higher risk than pedunculated polyps. Sessile polyps have higher risk than pedunculated polyps. So these are the conditions which tell us that there is a higher risk of conversion into a colorectal cancer in these patients. Now sometimes these villous polyps, yes, they can get converted into malignancy, but these villous polyps in the rectum, and these can be seen in children as well, these villous polyps in the rectum can give rise to mucus secretion can give rise to mucus secretion, and this mucus is rich in bicarbonate. This is rich in bicarbonate and sodium, right? So these patients are going to land up with hyponatremia because sodium bicarbonate is being excreted. There's going to be metabolic acidosis because the body is losing bicarbonate ions, and there can be hypoalbuminemia. So these are the features or the metabolic abnormalities which can be associated with villus polyps. This has also been asked in the exam. Now these villus polyps, there is a Haggett's classification, and this Haggett's classification is very, very important from the point of view of the Central Institute and the INI CET exam. Extremely important. This Haggett's classification tells us about malignancy in a polyp, right? And it ranges from Haggett's 0 to Haggett's 4. You should remember the details. First of all, remember the name, but please remember the details if you're preparing for the INI CET exam, please. So Haggett's 0 is non-invasive, there is severe dysplasia. Haggett's 1 is when it is restricted to the head. So Haggett's 1 is restricted to the head. Haggett's 2 is neck. Haggett's 3 is the stalk, right? Haggett's 3 is the stalk, right? And Haggett's 4 is below the stalk. Haggett's 4 is below the stalk. Now all these were about pedunculated polyps. So very important, one thing which I want to tell you is that Haggett's 1 I told you was the head. Haggett's 2 was the neck. Haggett's 3 was the stalk. And Haggett's 4 is below the stalk. But all these are for pedunculated polyps. Okay. If it's a sessile polyp, and this is a very important statement, if it's a sessile polyp which has a malignancy, it is straight away level 4. And this question has also been asked in the exam. It is straight away level 4. There is no 0, 1, 2, 3 in a patient with sessile polyp. If a patient with a sessile polyp has a malignancy, it is straight away level 4. One more significance of this point which I want you to know, till level 1 and 2, a pedunculated polyp, we can carry out endoscopic resection. Till 1 and 2, if there is a malignancy, we can carry out endoscopic resection as well. Below that, we need to carry out a proper open surgery for these patients. Now, this is transanal surgery which can be used for resection of polyps. You can go through the anal route, there won't be any incision, and you can just resect the polyps from inside. This is endoscopic resection. If you have a pedunculated polyp, if there is a pedunculated polyp, we can use a snare to carry out the polypectomy. Now, if it is a sessile polyp, which is not malignant, but it is symptomatic and we need to deal with it. If it is not malignant, but we need to deal with it, so snare would be difficult to pass because it is flat. I can't pass a snare around it. So what we do in sessile polyps is we infiltrate local and saline beneath the polyp. We infiltrate local and saline beneath the polyp, so that is going to raise the polyp. You can see that we are infiltrating saline. This raises the polyp, and now I can pass a snare around it. So for a pedunculated polyp, straight away you can use a snare, but if it's a sessile polyp, you first need to lift up the area by infiltrating saline, and then you use the snare to remove this. Now, the reason why I'm telling you about these adenomatous polyps is because there is an adenoma carcinoma sequence, and this adenoma carcinoma sequence is the one which is responsible for majority of the colorectal cancers. This adenoma carcinoma sequence was described by Vogelstein. Vogelstein was the scientist, and Vogelstein said that as these polyps gather more and more mutations, it gradually gets converted into a malignancy or a colorectal cancer. So there is a gradual accumulation of these hits or these mutations over a period of time which predisposes these patients. Now it's important for us to know these mutations because they've been asked in the exam. So you need to know that first you have a normal epithelium. Normal epithelium is there. And the first hit is the APC gene mutation. So the first hit is APC gene. This is very important. First hit is APC gene mutation on chromosome 5. And this converts it into an early adenoma or dysplasia. Right? This is when dysplasia starts. Then you have KRAS mutation. The second one is KRAS mutation, which converts it into an intermediate adenoma. From an intermediate adenoma, there is loss of SMAD gene. SMAD gene converts it into a late adenoma. And the final hit, this is very important, the final hit is P53. The final hit is P53, which converts it into a malignancy. Right? So simple way to remember it, I'm talking about hits. So just remember AK-53. Right? So just remember it like a gun, AK-53. So first is APC, then is KRAS, then you have P53. So first mutation is APC gene and the final hit is P53. And that converts it into a cancer. This is the classical adenoma carcinoma sequence. But around 10% of colorectal cancers can develop according to the alternate pathway. This was the classical pathway. There is an alternate pathway as well. And alternate pathway is due to mutation of the mismatch repair genes. It is due to mutation of the mismatch repair genes. MSH and MLH, and I'll talk about these in detail when I talk about HNPCC syndrome, where these genes are mutated. So majority are due to the classical pathway, 10% are due to the alternate pathway as well. Now there are couple of syndromes which we need to talk about in relationship to adenomatous polyps. Like we discussed the hematomatous polyp syndrome, similarly there are certain syndromes related to adenomatous polyps as well. And the one from which majority questions have been asked is FAP syndrome. FAP stands for familial adenomatous polyposis coli syndrome. Right? FAP syndrome. This FAP syndrome is an autosomal dominant syndrome and it is because of an APC gene mutation on chromosome 5. It is APC gene mutation on chromosome 5. And the hallmark of FAP syndrome, the hallmark is that there are more than 100 adenomatous polyps. There are more than 100 adenomatous polyps. Rectum is the most common site. Rectum is the most common site for these adenomatous polyps, but there is a variant of FAP syndrome as well, and you should know this. There is something known as attenuated FAP. There is something known as attenuated FAP, and in attenuated FAP there are less than 100 polyps. There are less than 100 polyps. Now these patients have more than 100 adenomatous polyps and there is a 100% risk of colorectal cancer in these patients. There is a 100% risk of colorectal cancer. Those who have this syndrome, if it is left untreated, will definitely develop colorectal cancer. Right, so the clinical features how these patients present, these patients can present with bleeding PR. These patients can come with bleeding PR, alteration of bowel habits. They can come with alteration of bowel habits. They can come with pain. And the diagnosis is made on colonoscopy. Diagnosis is made on colonoscopy. In colonoscopy, we examine the entire bowel right from the rectum till the cecum. And it is important to go through the entire large bowel to see how many polyps are there and which all are the sites which are involved. So when we do a colonoscopy, this is the appearance where you can get the entire colon studded with colorectal polyps. Now, if FAP syndrome is present, if FAP is present, then we need to manage the patient surgically. Then we need to carry out surgical management for these patients. And if you remember the module on inflammatory bowel disease, I told you there also that the surgery which is carried out is known as total proctocolectomy, plus IPAA, ileoanal pouch anastomosis. Ileoanal pouch anastomosis. That is the surgery which is done for FAP syndrome. That was the surgery which was done for ulcerative colitis as well. So in this surgery, what we do is that this is the ileum, this is the cecum, ascending colon, transverse colon, descending colon, sigmoid, and you have the rectum. So FAP can start from the rectum and it will only be there in the large bowel. So this is the area where polyps can be there. So in this surgery, what we do is that we remove the terminal ileum, we remove the entire colon along with the rectum. We only leave the anal canal behind. So even the rectum is removed, just the anal canal is left behind. So this is what we are left with. We are left with the anal canal here. This is the anal canal which we are left with. And we are going to anastomose the ileum. We'll make a pouch of the ileum so that there is a reservoir and fecal matter can accumulate there. And it is usually a J-shaped pouch of the ileum. It is a J-shaped pouch of the ileum which we anastomose with the anal canal directly. That is why ileoanal pouch anastomosis is there. I told you two questions when I was talking about inflammatory bowel disease as well, that the most common complication of this surgery is pouchitis, that is inflammation of the pouch, that is pouchitis. But the most common cause of death in these patients, following this surgery is small bowel obstruction, is small intestinal obstruction. So this is the surgery which is carried out in these patients, so you should know about it. This is important for the exam. Now, before I tell you the screening of a patient, of a family member who has had FAP syndrome, I want to tell you that there are two variants of FAP syndrome. These two variants have been asked multiple times in MCQ exams. The first one is Gardner syndrome and the other one is Turcot syndrome. So in Gardner syndrome, patients can have features of FAP. They can have sebaceous cysts. There can be sebaceous cysts which can be seen. Osteomas can be seen in these patients. These patients can have desmoid tumor. Desmoid tumor is a soft tissue sarcoma involving the anterior abdominal wall. This I have covered in the skin and the soft tissue tumor module. Desmoid tumor usually develops over the region of a scar and it is a soft tissue sarcoma involving the anterior abdominal wall. So these are the features of Gardner syndrome. Turcot is an autosomal recessive syndrome and there can be FAP and there can be CNS tumors which can be seen here. Now the most common CNS tumor, the most common is glioblastoma, right? But in children, the most common, if you're asked children, then it is a medulloblastoma. In children, it is medulloblastoma. Meningiomas can also be seen, but most common is glioblastoma. In children, it is medulloblastoma. This is Turcot syndrome. Now, another thing which has been asked in the exam, that if you have a first degree relative of a patient with FAP syndrome, right? So in this first degree relative of a patient with FAP syndrome, first we carry out genetic counseling. We tell the patient and the relative, what exactly is the problem, and why do we need to do a genetic testing in them. So after genetic counseling is genetic testing, and if this relative tests positive, if APC gene is mutated, then what do we need to do? Then we need to start screening at 10 years of age. Please remember this. Then screening starts at 10 years of age. And I'll cover later on in the module that the best screening modality for colorectal cancers is colonoscopy, because colonoscopy we can see from the rectum right up till the cecum. But we know that rectum and the sigmoid is the most common site for these polyps in FAP syndrome. So at 10 years of age, what we do is we start with sigmoidoscopy. Sigmoidoscopy is done annually in these patients. And if polyps develop, if polyps are seen, then we carry out the surgery, which we've already discussed is total proctocolectomy, followed by ileoanal pouch anastomosis. Usually polyps develop by 13 to 15 years of age. Usually polyps develop by 13 to 15 years of age. If no polyps till 18 years, then the risk of cancer is same as general population. If these patients don't develop polyps by 18 years of age, good for that patient, because sometimes the gene does not penetrate, does not complete penetrance, and those patients who don't develop polyps by 18 will have the same risk as the general population, and then you can stop the screening also in these patients. Right, so this is a FAP syndrome. You should know about it. It is important for the exam. The other syndrome which you should know about is HNPCC syndrome. HNPCC is hereditary non-polyposis. It is hereditary non-polyposis. So the name itself is suggesting that there won't be any polyps here. Non-polyposis colonic cancer syndrome. So hereditary non-polyposis, no colorectal polyps will be formed here, and this is due to mutation of the mismatch repair genes. This is due to mutation of the mismatch repair genes, that is the MSH2 and the MLH1 gene. And out of these two, MSH2 is the most commonly involved gene in HNPCC. Now, these genes also exhibit microsatellite instability. They also exhibit microsatellite instability, and this microsatellite instability is detected by the Bethesda classification. Now, please don't get confused. We had done Bethesda classification in thyroid also. That was the classification for reporting FNACs in thyroid. Here, Bethesda classification is to exhibit microsatellite instability, right? So don't get confused between the two. And these gene mutations can give rise to Lynch syndrome. This is also known as Lynch syndrome. And Lynch syndrome can be of two types. You can either have Lynch 1 syndrome. Lynch 1 syndrome, only colorectal cancer risk is increased. Colorectal cancer risk is increased, and unlike FAP syndrome where the risk was 100%, here the risk of colorectal cancer is 70 to 80%, right? The risk is 70 to 80%. And you can also have a Lynch 2. Lynch 2 is for extracolonic cancers. Lynch 2 is for extracolonic cancers, and in the extracolonic cancers, this has been asked in the exam, within the extracolonic cancers, uterine cancer is most common. So again, don't get confused. The overall most common cancer in HNPCC or Lynch syndrome is colorectal. Overall most common is colorectal. The most common extracolonic cancer is uterine cancer. And the other cancers it can give rise to are ovarian cancer, pancreatic cancer. The other cancers are ovarian and pancreatic cancer. Right, so that is a Lynch syndrome which you should know about. And how do we diagnose HNPCC? For a diagnosis of HNPCC, you have the modified Amsterdam criteria. You have the modified Amsterdam criteria. So you should remember the name modified Amsterdam criteria. Fortunately, the details of this have not been asked till now, but I'm just going to tell you the details. This is especially relevant for those who are preparing for the INI CET exam. You should know the details of the modified Amsterdam criteria. So the modified Amsterdam criteria, first we need to rule out FAP. That is the most important. Rule out FAP. Second, at least 3 family members. At least 3 family members should be affected. At least 3 members should be affected with Lynch tumors, which Lynch syndrome tumors. At least 3 family members should be affected. At least 2 successive generations should be affected. At least 2 successive generations should be affected. At least 1 should be diagnosed before 50 years of age, less than 50 years of age, and at least 1 should be a first degree relative. So these are the criteria which need to be fulfilled for us to say that the patient has HNPCC syndrome. Right? This is the modified Amsterdam criteria. Again, no confusion. To detect microsatellite instability, Bethesda classification. For diagnosis of HNPCC, modified Amsterdam criteria. Okay. There is one more syndrome which you should know. This is known as Muir-Torre syndrome. This is a variant of HNPCC. Muir-Torre syndrome is a variant of HNPCC. This is characterized by benign and malignant. This is characterized by benign and malignant tumors of the sebaceous glands. Benign and malignant tumors of the sebaceous glands. There can even be keratoacanthomas in these patients. There can be keratoacanthomas in these patients as well. So this is Muir-Torre syndrome, which you should know about. Now, another thing before we move on to colorectal cancers. So FAP versus HNPCC, I've told you certain differences. FAP tumors are going to occur after polyp development. HNPCC, there is no polyp development which is there. In FAP, 100% risk, if FAP is there, colorectal cancer will develop. HNPCC, it is 70 to 80% risk. When there is a FAP mutation or APC gene mutation, tumor initiation is accelerated. Remember this, I told you APC is the first hit which is there, okay? Whereas tumor initiation in HNPCC is normal. But tumor progression in HNPCC is accelerated. Once the tumor forms, then HNPCC tumors progress faster as compared to FAP tumors, okay? So this is another difference which you should know for the exam. Now moving on to colorectal cancers. Now colorectal cancers, the first thing which we need to talk about are the risk factors for colorectal cancers. And the risk factors for colorectal cancers include alcohol, a high fat diet which is rich in red meat. And there's another point which I want you to know here. A high-fat diet which is rich in red meat increases the risk of cancer, but a low-fat diet is not protective, okay? And this was a favorite PGI question asked so many times. So high-fat diet is a risk factor, but low-fat diet does not reduce the risk. Please remember that, please. Then other risk factors, if you have a ureterosigmoid anastomosis, if you remember the module on bladder, I told you that after bladder resection, ureterosigmoid anastomosis was carried out, and there is 100 times risk of colorectal cancers at the site of anastomosis in ureterosigmoid anastomosis. So this is another point which you should remember. Risk factors are polyps, adenomatous polyps, which we've already discussed. Inflammatory bowel disease. Inflammatory bowel disease, you know, ulcerative colitis has a higher chance than Crohn's. Ulcerative colitis has a higher chance than Crohn's disease. And you should also know selenium deficiency. Selenium deficiency. And if there is a family history of colorectal cancer. So these are the risk factors for colorectal cancers, but you should also know what are the protective factors in colorectal cancer. So protective role. NSAIDs have been proposed to have a protective role. Selenium has a protective role, and high roughage diet, high fiber or high roughage or high fiber diet also has a protective role, although there are certain latest studies which are written in Harrison which say that this role is also controversial. But as of now, there are certain books which still say that high fiber diet has a protective role, so we are going to go with that right now as well. So these are the risk factors for colorectal cancers. Colorectal cancers, the most common site for colorectal cancer is the rectum. The most common site is the rectum. If you're asked the most common colonic site, then the answer is sigmoid colon. So if you have to arrange them in order, it is rectum, then rectosigmoid, then sigmoid. But rectum overall is the most common. But if you're only asked colonic, then you will mark sigmoid colon as the answer. So before we talk about the clinical features of colorectal cancers, let's talk about screening for colorectal cancers. I've already told you the 4 cancers in which screening reduces mortality are breast cancer, prostate cancer, cervical cancer, and colorectal cancer. So colorectal cancer falls in one of those 4 cancers where screening reduces mortality. So let's discuss what are the various screening modalities for colorectal cancers, because a lot of questions have been asked regarding this. So the best screening modality for colorectal cancers is colonoscopy. And you know, colonoscopy, the length of the colonoscope is 110 to 140 centimeters. If you remember the module on upper GI hemorrhage, I've shown an image of a colonoscope and an upper GI endoscope. And I've told you that the only differentiator is the length. Colonoscopes are 110 to 140 centimeters, whereas an upper GI endoscope is 80 to 100 centimeters. Okay, so you can refer to that image in the upper GI hemorrhage module. Now, colonoscopy is right from the rectum till the cecum. So this is the advantage. We can screen the entire large bowel from rectum till cecum. That is why colonoscopy is the best. And this is the best. And screening age, when should this start? Should be started at 50 years of age. Started at 50 years of age. But if family history is present, then 10 years before the diagnosis of youngest relative, it should be started. Okay, so one point which I want you to know here, it should be started at 50 years of age, or if there is a family history, then 10 years before the diagnosis of the youngest relative. But mind you, supposing the patient, the youngest relative was diagnosed at 65, then you won't start it at 55, you'll still start it at 50. So you have to start at 50, but if the 10 years is coming less than 50, then you start it at that age. And colonoscopy as a screening modality is done once in 10 years. But this is the best screening modality. This you should know about. The next screening modality is sigmoidoscopy. So sigmoidoscopy can see up till 60 centimeters. We are only seeing the sigmoid. We are only seeing the sigmoid, and this is once in 5 years. This is done once in 5 years. And FOBT is fecal occult blood testing. Fecal occult blood testing. Fecal occult blood testing, this is done every year. So these are the three conventional screening modalities for colorectal cancers. I've told you the age at which it is done, and colonoscopy is the best one which you can carry out. There are a lot of experimental screening modalities also which are being worked upon, like they are analyzing the mutations in the fecal matter, right? They're chromosomal and mutations in the fecal matter, and in future that might turn out to be the best non-invasive method of screening for colorectal cancers. But as of now, it's just an experimental modality. Another thing which is gaining a lot of popularity is virtual colonoscopy. Now, everyone doesn't like a scope being shoved up their backside, right? So they're all looking for alternatives, and one of them is virtual colonoscopy, which is nothing but a CT or an MRI followed by 3D reconstruction. This is CT or MRI followed by 3D reconstruction, and you can see the image here. You can get a clear view of the bowel, and this can be a substitute for conventional colonoscopy. The advantage of virtual colonoscopy over conventional colonoscopy is that this is non-invasive. This is a non-invasive. Extracolonic details are better visualized. Extracolonic details are better visualized in this modality, and this is good for detecting lesions more than 6 millimeters in size. But conventional colonoscopy will give you better intra-cavity details, or within the lumen, the details, minute details you would be seeing better with conventional colonoscopy. Extracolonic with this one, but inside the colon, conventional colonoscopy trumps this modality. But you should know about this. This has been asked in the exam. So we've discussed the screening modalities as well. Let's talk about the clinical features of colorectal cancers. Now, the clinical features of colorectal cancers, let's divide them into right-sided and left-sided lesions because they both present in a different manner. Now, right-sided lesions are mainly ulcerative in nature. Right-sided lesions are mainly ulcerative in nature. And because they are ulcerative in nature, they bleed commonly. And when they will bleed, the patient will come with iron deficiency anemia. Patient is going to come with iron deficiency anemia. There's going to be weakness. There's going to be weight loss. But because they are ulcerative, they are not obstructing. Alteration in bowel habits is late. Alteration in bowel habits is a late feature. So this is the presentation of right-sided lesions. Alteration of bowel habits is a late feature. Obstruction is a late feature. Left-sided lesions are annular or constricting growths. These are annular or constricting growths, and because they are annular or constricting growths, obstruction and alteration of bowel habits is early. Obstruction and alteration of bowel habits is an early feature in left-sided lesions. Patient can come with tenesmus, change in bowel habits. These will be early in left-sided lesions. And because these are constricting growths or annular growths, left-sided colorectal cancers, left-sided lesions, you can get an apple core deformity. Once we eat an apple, then you can see that on both the edges, some bit of apple is still left, but the center is completely empty because we eat quite a lot in the center. So you get an apple core deformity. This is an apple core deformity which you can get in left-sided colorectal cancers. And I've discussed the clinical features with you as well. If we talk about metastasis, colorectal cancers can have local invasion or spread local invasion. They can metastasize to the lymph nodes, and they can show distant metastasis. And distant metastasis most commonly is to the liver. This question has also been asked in the exam. Liver is the most common site for distant metastasis from colorectal cancers. Now, what is the workup of the patient? So the workup of the patient, we've already discussed that we would do investigation to confirm the diagnosis. So what is the investigation of choice to confirm the diagnosis? I will do a colonoscopic biopsy. I'll do a colonoscopy and I will do a biopsy. Now, why not just do a sigmoidoscopy? Why do a colonoscopy? I told you that colonoscopy has an advantage that it can see right from the rectum till the cecum. And why do I want to see that? Because I told you that colorectal cancers can also show field cancerization. Field cancerization, if you remember, we discussed in oral cancers and in bladder cancer. And what was field cancerization? Field cancerization was that multiple tumors can arise in these areas. Multiple tumors can arise in these areas, and 4 to 5% synchronous tumors can be there in colorectal cancers. Means at the time of diagnosis, 4 to 5% patients might have multiple tumors, which is why it is imperative that we do an entire colonoscopy and not just a sigmoidoscopy. You should see right up till the cecum to rule out synchronous lesions. Once we've clinched the diagnosis, the investigation of choice for staging is PET-CT, positron emission tomography. 18 FDG is the isotope which is used. This I've repeated multiple times. One particular question which you should know, the investigation of choice for T and N stage of rectal cancer. I'm not saying colorectal, I'm just saying rectal cancer, T and N stage. This has also been asked many times. It is an MRI with endorectal coil. MRI with an endorectal coil is the investigation of choice to look at the T stage and the nodal staging of rectal cancers only. Now, the TNM classification of colorectal cancers is important because in one of the UPSC exams, they had asked a question regarding this, and there are a lot of 8th HSCC updates in this as well. So quickly, let's go through the TNM classification. You know TNM is tumor, node and metastasis. T is for tumor, and unlike breast, unlike thyroid, unlike oral cancers, where the T stage is dependent on the size, in GI tumors, the T stage is dependent on the depth of invasion. Okay, so you have Tx when we cannot assess the tumor, T0 is no tumor, TIS is in situ cancer, T1 is when it invades into the submucosa, that is T1, T2 is when the muscle layer is involved, T3 is when it goes through the muscle layer into the pericolorectal tissue, and T4 is when adjacent structures are involved. So T4A is through visceral peritoneum, and T4B is when other organs are directly involved. The nodal staging, again nodal staging, N1 is 1 to 3 lymph nodes, N2 is 4 or more lymph nodes. You don't need to remember ABCs, this you can get rid of. N1 is 1 to 3 lymph nodes, N2 is 4 or more lymph nodes. Distant metastasis, M0 is no distant mets. M1 is divided into M1A, B and C, which I'll tell you in detail. This is an 8th HSCC update, which you should remember for the exam. So the first 8th HSCC update which I want you to know is that T4 has been separated into T4A and T4B. T4A is direct invasion of the serosal surface through inflammation. So if the serosa is involved, it is T4A. T4A should not be used for non-peritonealized. So serosa, it should not be used for non-peritonealized portions of the colorectum. Okay, it should only be used for those areas which are surrounded by peritoneum. And one more very important thing, minimum 12 lymph nodes should be removed for accurate staging. If you remember breast cancer, I told you how many lymph nodes? 10 lymph nodes were being removed from the axilla minimum. Here minimum 12 lymph nodes need to be removed. Also told you M is divided into M1A, M1B and M1C. M1A is metastasis confined to one organ or non-regional lymph nodes. So two things make it M1A, one organ or non-regional lymph nodes. M1B is two or more organs without peritoneal mets, no peritoneal mets. And M1C is if the peritoneum is involved along with other organs or other mets, that would make it M1C. So these are the TNM updates regarding colorectal cancers which you should know about. Now, in addition to the TNM staging, there is another staging which was a pet favorite of the JIPMER exam. But now with the INI CET exam and everyone pooling in questions, you never know if it can be asked again. It might be asked again in the INI CET exam as well. And this is the Duke's staging for colorectal cancer, also known as the modified Asler-Cola classification. Also known as the modified Asler-Cola classification. So what is the Dukes or the modified Asler-Cola classification? Let's just see here. Look, this is the mucosa. Beneath the mucosa, you have the submucosa. The yellow one is the submucosa. Then you have the muscle layer. This is the muscle layer. And finally, you have the serosa. Finally, you have the serosa. So if I just label, this is the mucosa, yellow one is the submucosa, this is the muscle layer, and the red one is the serosa. So Dukes A is when the tumor is in the mucosa and the submucosa, that is Dukes A. So Dukes A is mucosa and submucosal involvement is Dukes A. Dukes B is divided into B1 and B2. B1 is when the tumor goes into the muscle layer, when the tumor goes into the muscle layer but not beyond it. Into muscle layer but not beyond it. Whereas B2 is when the tumor goes beyond muscle layer. When it goes beyond muscle layer, it is B2. But you can see that both B1 and B2, no lymph node involvement is there. Okay, no lymph nodes involved as yet. You have C is divided into C1 and C2. C1 is when it goes into the muscle layer, like B1, it has gone into the muscle layer, but there is presence of lymph nodes. But lymph nodes are present. And C2 is like B2, it has gone beyond the muscle layer, plus lymph nodes are there, that is C2. So C mirrors B, but there is presence of lymph nodes. So that is different, please remember that. And D is distant metastasis. D is distant metastasis. So in addition to the staging, this is also of prognostic importance. This tells us about the 5-year survival in patients with colorectal cancer. The 5-year survival, again very easy to remember. The 5-year survival for Dukes A is 90%. For B is 60 to 70%. So 30 you've reduced. C is 30% and D is less than 30%. Right, so just keep on reducing 30, 30 and you can easily come to the 5-year survival. So Dukes, in addition to staging, also tells us about prognostic importance. So this was the staging of colorectal cancers. We now move on to the management of colorectal cancers.